Good morning.
Hey, good morning.
So, some of you I do know, a lot of you do. I don't think I've ever met you. Nice to meet you. Former employee, great staff. I miss all of you guys. So, my name is David, for the folks that don't know me. I'm a respiratory therapist at Good Samaritan Hospital. I'm actually the education. I do the education for Good Sam, and I was asked to come down here and go over some vent modes. Now, there's a variety of experience levels in this room right now. I respect every seasoned therapist in here, so I'm going to make sure that I'm going to assume that everybody's in the same level playing field. I'm going to start from the bottom.
Yep.
Okay?
Good.
So, hey, how are you?
Hey, what's up?
So I'm going to start from the bottom, okay? And then we'll work our way up. Specifically, I want to leave this more of an open forum. So if you have any questions, I'll be more than happy to take the time if something's not clear or anything like that. Please go ahead and raise your hand and we'll answer it. Because if you're thinking that question, maybe somebody else is thinking the same thing too. So it's better to answer that and move forward. Okay? So first and foremost, here you only use 3 major vent modes, right? It's volume AC, volume SIMV, pressure support ventilation, and maybe PRVC, right? Or starting to toy with PRVC.
Yeah.
Okay. So we'll go over some of those as well. And no APRV, right? No APRV.
No.
Okay. Okay.
Not yet.
Okay, cool. Not yet. That's a great start. So let me ask this generally speaking. Why do we breathe? And I ask this from, why do we breathe? Well, no, what's our mechanism behind it? Of course. Okay, what's the mechanism that drives us to breathe?
Exchange the gas,
What gas?
oxygen and CO2.
Does everybody agree oxygen first and CO2?
CO2 and oxygen.
CO2 first, and then oxygen, right? So our bodies are constantly metabolizing. The byproduct is CO2. Our lungs pick that up, collect it, and move it out. The movement of CO2 is called ventilation. When that ventilation ceases to exist, or there is a high accumulation of CO2, we call that respiratory failure. And that's where we come in, correct? Because we have to make sure that there's a certain number that we have to look for, right? There's a certain number that we have to look for that tells us whether or not we are ventilating appropriately or not. If it's higher than 45, we know that that is not ventilating enough. If it's less than 35, then we're ventilating too much. There are some instances where the rules are broken, right? We have our COPD patients, our neuro patients that usually require a lower amount of CO2. But generally speaking, this is the rule that we abide by, correct? Mm-hmm. Apart from the patient's altered level of consciousness, where we might have to insert an advanced airway to help them protect their own airway. Now, what is the most common mode that is used by the doctors today? Volume. Why? Why is it easy for doctors to say, you know what, put them on tidal volume 500? Ever think about that? Why? Why is it because if our entire reason for ventilating was to control CO2, the easiest way to control CO2 is by controlling the patient's tidal volume. And not only that, but guess what? I can calculate tidal volume. So I can have, remember, MDs make decisions, right? Mm-hmm. So their whole spiel is control. I control tidal volume, I control CO2. And if I can calculate the tidal volume, I can have even more control of my gas exchange. Here's the problem. That the modes that we have today are a little bit out of date. Okay? So if we have a tidal volume that we control, for example, let's say that the doctor orders 500 mLs, and we have a lung, those are my lungs, I'm sorry. Okay? And we have a lung, we're thinking, okay, 500 tidal volume is going to go in evenly, right? 250, 250. But that's not necessarily the case,
Right.
right? So this patient may want to breathe on their own. So we have two ways that we deliver tidal volume. We have something that we call volume control, right, where we control the tidal volume. And the other one is called pressure control. Well, we've established this is the doctor's favorite because they have total control of the CO2. But the way that the vent delivers this tidal volume, it doesn't care. It does not care at all. Because a lot of these patients will have atelectasis on one side, maybe a slight pneumo. Now, is it 250, 250?
No.
No. Maybe it's 150, 350. Now you're hyperinflating a good lung. Correct? So pressures are going to change on one side greater than the other. When you hyper expand anything, if I were to scratch myself, if I were to injure myself, same as the alveoli, what is the body's first response? If you ever smash yourself, boom, what's going to happen to my hand?
Swelling.
It's going to swell. That happens at a microscopic level as well. When things get unevenly distributed, when you are forcing a certain amount of ml, doesn't matter what the pressure changes are, you at the alveolar level are going to cause hyperexpansion, which then causes swelling, which causes micro injuries, and the response to that is swelling. Now you've gotten yourself into even more trouble. So what do? Well, we can avoid this from the beginning. And how do we do that? Well, we have modes that can go ahead and automatically adjust. That can automatically adjust the way that the volume is delivered. So that way the lungs are protected more, minimizing any type of micro damage, right? So we have our standard volume delivery assist control. This is the main culprit for this type of damage because it doesn't care. You told me I'm going to deliver 500 tidal volume. You just tell me how fast you want it because that's how much peak flow I'm going to get. Next thing you know, your FiO2 start going up, your oxygen, your peak inspiratory pressure start going up, and now you're fighting that demon where okay, now I have to increase my PEEP and my FiO2, and you're starting to get into acute lung injury. Well, with pressure regulated volume control, it takes these two worlds and combines them into one. Now, what does pressure regulated volume control do? What's the difference between standard AC and PRVC? Well, the first two letters are pressure regulated, which means that whenever I change my ventilator from delivering tidal volume and direct flow control, this flow control will shear the lungs. You want me to hold it? I'm going to just deflate it again. With PRVC, what it does is that it'll take your delivery and make it into more of a pressure controlled breath. So it'll change from flow delivery to more of a ramping inspiratory pressure. So why does it do that? Because when you change it over to PRVC, the ventilator does a quick inspiratory hold. Now, why is the inspiratory hold important? Can everybody do me a favor? Everybody take a nice deep breath and hold it. Dave, I want you to give my example. Stand up. Everybody take a look, Dave.
Oh, don't look at me.
Take a deep breath. Hold it. Hold it. Anybody notice what happened with Dave? Exhale. Take a deep breath again. Hold it. Exhale. What happened to Dave's chest? Expand. But what happened when I said hold it? Take a deep breath. Hold it.
It stays at where
Not true. No. Everybody take a deep breath and hold it. What happened to your shoulders? It dropped. And that's what PRVC is going to focus on. Okay? I'm going to take a deep breath. When you look at your peak peak pressure scaler, take a deep breath. This is your PIP. Hold it. This is your plateau pressure. That is the minimum amount of pressure needed to keep your alveoli open, and that's what PRVC is going to be measuring all the time. As opposed to straight volume control where I don't care what your plateau pressure is, I'm going to shear that lung. You want 500? I don't care if you have water on one side, air on the other, I'm going to force it in there. Pressure control will automatically adjust inspiratory pressure to give you the least amount of pressure needed to get the tidal volume in there. And it will adjust it with every single breath. Why is this important? Because the less peak inspiratory pressure you have, the less intrathoracic damage you'll have, and the less barotrauma you'll cause the lungs, which will lead to less alveolar or micro damage in. This is why volume AC is more of an old school thought now. But the doctors love it because they can control CO2 directly. That's all they care about, right? I don't care. What's the blood gas? What is the CO2? I don't care how you got it in there. Do you think they asked for peak pressures? No. What's the result? It is your responsibility to know what the peak pressures are because you're dealing with it. So, given the option, if you can have a CO2 of 40 with a peak pressure of 55 or a peak pressure of 30, you as respiratory therapists would choose which?
30.
30. The doctor's not going to care about that. The doctor's going to say, just give me the CO2 down. That's all I care about. It is your responsibility to know that the delivery of this machine is for not only your benefit, but overall the patient benefit. And in the long run, it'll cause less damage. So when we look at PRVC, it's going to ask you for a couple of things. Well, one's the respiratory rate, of course. Second is the tidal volume. And third is the I time. Why is the I time important? Sorry.
Is that improve oxygenation?
Well, it can and it can't. Because if you're asking for 500 tidal volume, the machine's going to say, okay, I'm going to adjust the flow. Now, let me ask you something. Has everybody ever driven here with your hand out, in the car with your hand out of the window? Have you driven with your hand out of the window at 10 miles an hour? Nice little breeze, right? Have you done it at 100 miles an hour?
Yeah.
What happens?
Resistance.
Boom. So flow at a high speed creates pressure. And that's what PRVC does. It adjusts the flow based on the lung compliance to create pressure. You determine how long you hold that pressure for. Here's the thing. When we look at our flow scaler, remember the take a deep breath and hold? What does holding do? If I take a deep breath and I hold, what happens? Intrathoracic pressure increases, mean airway pressure increases, and it improves my oxygenation. So when we look at the flow scaler, what we're aiming for is that little pause. That's how you adjust your I time. You have to have an inspiratory pause. Okay? When you adjust that inspiratory pause, that means your tidal volume's been met, and at the same time, you're holding for oxygenation. Now, there's a reason why you want to start off anywhere between 1 second, maybe 1.2, and you want to really avoid going lower than that. Because the lower the I time, you will never reach the maximum amount of volume, and you're going to see that your tidal volumes are going to go down. Yes, ma'am.
So the I time and the inspiratory hold are basically the same?
You adjust your I time to achieve an inspiratory hold.
To achieve the hold.
Yes.
Okay.
So that have a little vent right here. So if you take a look at the second scalar, it's a little. Notice how my I time is a little bit greater than 1, but notice a little that inspiratory hold at the end. That's what we're aiming for. You see that? So if I minimize my I time, they will have no time to reach that tidal volume, no time for a reeler recruitment, and your oxygenation is gonna drop. This is why they call it baby I times. You don't want to go anything less. Ideally, I know. So Egan says, okay, anything less than 7.7 is not ideal. I would argue that. I would say anything less than 0.8. Because you are not, on an adult, depending on the size of the adult, you will not give that adult enough time to achieve that tidal volume. Much less hold, much less alveolar recruit. Remember, the whole purpose of PRVC is to minimize micro damage. If you deliver I times at 0.5, the flow is so turbulent, you are causing nothing but damage. Okay? Now, whether the patient tolerates this or not is a different story. Because with PRVC, if we control the I time to achieve this tidal volume so we can hold and oxygenate, correct? That is ideal. My patient right here is not moving. My patient right here is not distressed. My patient right here is not on dialysis, and he's not septic, and he's not in ICU. But what if he is? What if he starts breathing really fast? Well, the machine, PRVC, will change the inspiratory pressure plus or minus 3 centimeters of water pressure every breath to meet the demand of the tidal volume at the lowest pressure possible. This is also the worst thing about this machine, about that mode. Because if I'm breathing really fast, the machine's thinking, oh, David's compliance is good. I'm going to drop that inspiratory pressure as low as possible, which then means I won't get enough tidal volume. Right. So at that point, when the patient is tachypnic, he's agitated, you might want to change modes that'll help deliver more of a consistent inspiratory pressure to deliver that tidal volume.
So with the adjustment of I times, is there no need to monitor your ratios?
There is always a need to monitor your ratios.
So if you're, because what we're seeing with the new Hamiltons and using the PRVC,
yeah.
I think one of the issues that Jeremy and I were talking about is this: we're adjusting the I times in an attempt to get the IE ratios in sync.
Right.
Is that approach not correct?
That approach is correct if the patient is not in any trouble.
Okay.
What it sounds like what you're trying to do, what you're trying to tell me is that you're trying to keep up with the patient.
Right. So you go
So
in.
if the patient is tachypnic, you're chasing that demon. So you are not fixing the underlying cause.
Okay.
That is the problem. It's kind of like when you have a blood gas. What's the worst kind of blood gas that you might have? Respiratory or metabolic acidosis?
Respiratory. Well, metabolic.
Metabolic. You're chasing something you can't control, and you're trying to compensate it with CO2, which you can only do for so long.
Right.
Same thing with this I time.
Okay.
If you are trying to chase that underlying demon of sepsis or some sort of hypoxia or anemia that's causing this patient, that's resulting in this patient to become tachypnic, you need to fix that patient.
So then is there a diagnosis preference?
What patients
For
qualify for PRVC?
for PRVC?
Yes. Everybody. Everybody should be on PRVC. Why is that? Because everybody should have the lowest pressures available to deliver a tidal volume. The patients that will not tolerate is probably what you're asking.
Right.
The patients that will not tolerate are the patients that you have to keep on adjusting the eye time, because the pressure is going to be adjusted by the machine automatically. As soon as you start noticing that your eye times are going in the opposite direction of 1, we have a problem.
Okay.
Because now, are you going to have enough time to deliver that tidal volume?
No.
Are you going to have enough time for the inspiratory pause?
No.
No. So what's going to happen to your patients? They're going to...
So if you have a patient and you notice that the patient's IU ratios are becoming inverse, then you know that the
Right.
PRVC
Now-
is not.
Exactly. Now, there are instances where inverse ratio ventilation is necessary. But on PRVC, it's not ideal.
No.
Because with inverse ratio ventilation, you need a constant inspiratory pressure. This adjusts the inspiratory pressure.
Yeah. Only in
Right,
the inverse
right,
diversion
right. So
Y
this
level or something.
exactly.
like that.
So this PRVC is ideal for patients that you just intubated, patients whose lungs that you really want to minimize injury, and hope to get them off the vent as soon as possible. Now I know it's really hard to say that here,
Right.
but prolonged or long-term minimal injury is always ideal.
So is it safe to
So-
say that hemodynamically unstable patients
Would benefit
Would-
more from PRVC.
would benefit more
Yes.
from PRVC? So-
Why is that?
So your septicemia patients, these kinds of patients that we're receiving here, are better served on PRVC than
I would
on-
say depending on what the respiratory demand is at the moment. If the respiratory demand is super high, the minute ventilations are 15 or greater than 10,
Mhm.
where your eye times have to be adjusted, maybe not the best thing.
Okay.
Okay? But if they're stable enough where you're managing their minute ventilation
Mhm.
adequately, PRVC will deliver the least amount of pressure possible to get that tidal volume. And what is the problem with septic patients? Their blood
Blood
pressure.
pressure, right.
The blood pressure tanks. So if you have regular volume control, you are going to decrease their cardiac output. Too much interthoracic pressure will then cause venous return to drop. The nurses are going to be giving them drips like crazy, and all that water has to go somewhere. Where's it going to go?
Okay.
To the lungs. So if we choose a mode that can automatically adjust inspiratory pressure, because when we adjust the time, we adjust the flow, right? So the less of the flow, the less of the pressure, right? We have an ideal situation inside the lungs where we can get tidal volumes, adequate tidal volumes,
Mhm.
at a lower inspiratory pressure. Now, here's the thing. Remember we said flow equals pressure?
Mhm.
I can do this same thing on volume control.
Right.
I can literally do the same thing on volume control, but are you gonna sit there and measure every single breath and adjust the flow? No.
No.
Let the machine do it for you. This is why it's the best thing. They call this mode set it and forget it.
Okay.
Because you don't have to worry about adjusting any flow or inspiratory pressure. The machine will do it automatically for you, which is directly related to the patient's lung compliance. And this is going to be the determining factor
Right.
of whether the patient's going to tolerate or not. So this also has a cutoff point, and it's based off your high pressure alarm. Okay, so we said that the PRVC is going to go ahead and adjust the inspiratory pressure. Another name for inspiratory pressure is delta P, right? So, so it's gonna change the inspiratory pressure, but let's say that your high peak pressure alarm is 40 centimeters, because you know all you guys are. That's right. You guys are following the NBRC guidelines, right? That's right. Well, the PRVC
Respiratory to surgery, respiratory to surgery.
will adjust the inspiratory pressure at the max 5 centimeters below your high peak pressure alarm. So it'll cut off at 35 centimeters of water pressure. Does that make sense?
Yeah.
This is a safety mechanism.
Okay.
Okay? Because this is your pressure limit and this is your cutoff. Lung protection.
Okay.
Okay? So, if you want more inspiratory pressure, what are you going to do?
Increase your pressure.
Increase your alarms. But notice,
Housekeeping to
if you're increasing your alarms, there's something going on intrinsically with the patient. So, we're gonna start looking at lung compliance, your peak pressures and your plateau pressures. So here's the thing. Does anybody know what the difference between peak pressure and plateau pressures are? It's been a long time, I know. We just closed the books not too long ago. Who are my new grads here? New York grads. Peak pressure versus plateau pressure. Bueller. So, peak pressure.
Plateau pressure keep the alveoli open.
That's right. Remember, we took a deep breath and we held it.
Right.
That is the plateau pressure. This is the pressure needed to keep the alveoli open. Right? This determines my lung status. Normal plateau pressure, this is what we're going to look at, is 30 centimeters of water pressure. So, if my plateau pressure starts going up, that means my lung injury is going up. So if you notice that your PRVC starts peak pressuring and you have to adjust your alarm to get more volume in there, start looking at what is the underlying cause. Now, here's the thing. Peak pressure takes every single pressure and it says, hey, this is what's going on. This is like a red flag. I don't know what it is, but something's going on. Sometimes, to do this here, my peak pressure and my plateau pressure are affected. The difference is airway resistance. Airway resistance can be caused by anything, bronchospasms, secretion. This is why whenever you have your peak pressure go off, what's the first thing that we do?
Suction.
Suction. Because resistance can be, secretions can cause resistance in flow delivery. So we try to minimize this. But you suction, patients still peak pressuring. You give her treatment, patients still peak pressuring. You measure the plateau pressure and you notice it's at 40. It's not secretions, it's not bronchospasms, it is the alveoli itself. The alveoli is now the problem. So now when alveoli is a problem, now you need a lung protective strategy that's more advanced than PRVC. Now you need to control the pressure directly. Because if not, you're going to cause more shearing to the alveoli. And what's the automatic body's response to any type of injury is swelling. And swelling will decrease your compliance and so on and so forth.
So in this scenario, the recommendation would be to go from PRVC into direct pressure control.
That is
ventilation.
correct. That is correct.
And we would base as a therapist telling the doc, recommending to go into the PC ventilation. We would want to reference our compliance.
Compliance, plateau pressure, and if you're looking at blood gases, there's something that we call the PF ratio. And PF ratio lets us know what our PaO2 versus our FiO2 is. And
Bitch, I think I was going back to school.
so if you have a blood gas, your blood gas should tell you your PF ratio. If not, you can calculate it.
Your AA gradient, right?
Not necessarily. Your AA gradient is different. So your PF ratio is directly related to how much lung injury do I have.
Can we have an RT at one chair? Can we have an RT at one chair?
So if I have my PaO2 or my FiO2, right? So we're going to look at this as 3, 2, 1, 100. Okay? So everything, if you are in the 300s, everything is lung injury.
Dave,
But
I want to move your patient.
Yeah, they're gonna wait.
mild, moderate, severe.
No.
For pressure control, we're gonna look at plateau pressures that are greater than 30, peak pressures that are in the 50s, and PF ratios that are 200 or less. Now, I think you guys all got a handout. If you look at the second page, under pressure control, it gives you some of the criteria. I forgot to mention PF ratio in there, but it'll mention some of that criteria. So, if you start looking at your patient, and you notice that the patient's peak pressuring all the time, 50s, 60s, maybe 70s, depending on what your alarms are. Determine if it's airway resistance or if the alveoli is damaged. The way that you determine that the alveoli is damaged is that you look at the plateau pressures. If the plateau pressures are greater than 30, then you know that the patient's alveoli are getting damaged. What can cause that damage? Anything. Anything can cause. Swelling can cause that damage. Water with all that constant pressure can cause damage. Disease can cause that. Okay? But the problem is that we are looking at the patient's ventilatory needs at that moment to minimize lung injury. You never start on pressure control.
Oh, no.
You are forced into pressure control because it is a lung protective strategy measure. Does that make sense?
Yes.
Okay. So NBRC, right? You're never forced into pressure control. I mean, you never start with pressure control because with pressure control, there are some things that are there are some things that are different that can cause overall permanent damage. So we're going to look at 3 factors. If your plateau pressures are high, peak pressures are high, and your PF ratio is low, you need to protect that lung. And this is going to be your argument for the doctor. Because if the doctor ignores this, it's on you. It's on him. Make sure you CYA.
Yeah.
Okay? Document your findings. Try to do what you can on pressure, on PRVC to try to minimize that pressure if you can. But on pressure control, we're going to look at protecting the lung even further. Now, my knee grads. When you guys took your TMC, what is the order that they ask you to look at adjusting the machine? Whenever you look at fixing the machine or the vent, you always want to look at, is the patient ventilated? Is their CO2 okay? Is the patient exactly oxygenating? Right? Then circulation, which will lead then to perfusion. So we're gonna leave these two out. We're gonna focus on this. Ventilation and oxygenation. If I had to choose one to fight, one to fix, if I was forced to try to save one, which one would it be?
Ventilation.
Raise your hand, ventilation. Raise your hand, oxygenation. Raise your hand if you don't care. Okay. It's oxygenation.
I knew that.
Oxygenation. Why? Can I live in a hypercarbic state?
Yeah.
Yes.
Yes, I can. In a severely hypoxic state, you will have tissue damage like there's nobody's business,
I know
right?
that.
So, when we are forced into a situation that we don't like pressure control, we have to start thinking outside the box. Okay? Now, typically, when we look at volume control, and I calculate how much tidal volume, they tell you anywhere between 6 to 8 mLs per kilo of ideal body weight would be awesome. But on pressure control, if I change over to pressure control, see. What is not on there?
Volume.
Tidal volume. Am I controlling my CO2?
No.
No. I will not have full control of my CO2 as I would with PRVC or volume control. I have now lost the ability to control this. That's why doctors do not like pressure control. They will not have any control over tidal volume, and if they have no control over tidal volume, they will not have control of their CO2, which will then affect their pH and blah 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 blah. And if it's broke, and you show it to them, they are forced to fix it.
Right.
And what's the easiest way for them to fix that? Put them back on.
Volume.
Let's shear those lungs again. But you as respiratory therapists know you can't do that. Like plateau pressures are really high, peak pressures are really high, PF ratio is really low. You're going to be damaging these patients even more. So what do we do? Well, what did we do with Dave earlier on today? Take a deep breath and hold. Well, on volume control, I have my rate and my tidal volume.
James, pick up on 19980.
On pressure control,
Pick up on 19980.
I have my rate
James,
and I have my inspiratory pressure, what they call the delta pressure. And this is your plateau pressure. And we want these plateau pressures, this inspiratory pressure, to start off ideally less than 30, because greater than that, you're going to be introducing injury already. So we want to start off less than that. Okay? So the way that you calculate your inspiratory pressure, you take your plateau pressure, right? But what if you already have PEEP on it? You got to subtract that out.
Right.
So your plateau minus your PEEP equals your inspiratory pressure when you take on pressure control.
So that gives you your starting point.
That gives you your starting point. Now, tidal volume on inspiratory pressure is directly related to lung compliance. If my lung compliance is crap, the volume I'm going to get is crap. So you might have to adjust your inspiratory pressure to improve your tidal volume. Does that make sense?
Yeah.
Now, we also have eye time, which kind of reminds us of PRVC, right? So eye time will be adjusted to will be adjusted to meet this inspiratory pressure and hold it there. So remember, we want to make sure that when we look at our flow scaler, we are aiming for this inspiratory pause. When we reach this inspiratory pause on pressure control, this is not my tidal volume that's met, this is my pressure that's met. And the inspiratory pressure will let me know how much tidal volume I'm getting based off the lung compliance that the lung is measuring. Does that make sense?
Mm-hmm.
So if my lung compliance is crap, my tidal volume is crap, the difference is that now I'm taking more care of the lung because I am going to be aiming and distributing the pressure evenly on both sides of the lung.
Mm-hmm.
So if I have atelectasis on one side and nothing on the other, pressure control will take that into consideration. Which is why when you look here, when you have this pause, for this second, for that one time, the machine is telling you there is even pressure from the mouth to the base of that lungs that will improve your oxygenation. This is why whenever you change over to PRVC, sometimes you notice your oxygen goes up right away.
Mm.
Yeah, because that's what it's doing. It's equating, it's equalizing the circuit pressure with through the ET tube and the lungs. It's constantly ready to go. And since flow at a high speed creates pressure,
You want to lower
peak
that.
flows are always high on eye time. So if you have somebody that's septic, tachypnic, and cannot tolerate PRVC, switch them over to pressure control and it will synchronize even better. Because their flow demands will always be met. Flow is constantly high, you're just controlling how long you're going to hold it for. Now, will you achieve this all the time? That's your goal. You won't achieve it all the time. especially if the patient is agitated or tachypnic or anything like that, which is why you have to make sure that the patient is controlled first. It is your job to meet the patient's inspiratory demand, yes, but it is also your job to work in conjunction with the nurse to make sure that she is aware of what she needs to do. Wink, wink. Wink, wink. Right? Push that extra bolus. Right? So, but again, you are forced into pressure control because PRVC or standard volume AC was either giving you high peak pressures, your plateau pressures were going high, and your PF ratio was less than 200. So now, when we look at pressure control, our settings, what we usually do is that we have a set rate and we have a tidal volume goal. So we can automatically adjust the inspiratory pressure to meet that tidal volume goal. And that's the best way that the doctors will have control of CO2. Yeah, go ahead and adjust it. But be very careful, okay? What Spider-Man say? With great power comes great responsibility. So when you are in charge of changing the inspiratory pressure and you're like, oh, well, I'm not getting anything. I'm gonna go from 30 to 50. Bro, come on, not there. You gotta adjust it 3 centimeters at a time max and see what you get. Because if you are still getting this on pressure control, now you are in the world of hurt. Well, the patient is. Now we have to go into something called acute respiratory distress syndrome protocol. What they call ARDS-NET protocol. And what does that tell you? Well, we're no longer going to be aiming for perfect CO2. Could we have obtained it possibly? Yes, if the lung compliance is good, but the lung compliance is no longer good. And now we have to make sure that our entire organs don't go into failure, so we have to assure oxygenation. So instead of 6 to 8 ml per kilo, because instead of having this much space in my lungs to breathe, I only have this much space in my lungs to breathe. I have to work with lower tidal volumes, 4 to 6 mLs per kilo, and my respiratory rates are going to be higher than 20 or higher. Rapid, shallow breathing, slow, low, and fast. And usually this is associated with higher level of PEEPs, which leads me into my next section, COVID-19. What is the main problem with COVID-19?
Oxygenation.
Oxygenation. Why?
Because the lungs is stiff, and they have like high peak pressure.
That's true.
High plateau pressure.
That's true.
But low all true.
That's true. That is all true. So let me ask you this. Syndrome. What's the difference between a syndrome and a disease? A disease I can test for directly. Cystic fibrosis, oh, give me a sweat chloride test. Positive or negative, you got that. A syndrome is not like that. A syndrome says, oh, I have this, I have this, I have this. All together, I have ARDS. One of those things that we look at now with COVID-19 is we have swelling, we have peak pressures, but you also have a positive test that once the virus infects your lungs, it causes swelling in one area. It then irritates the entire lung completely, causing your entire lung to become swollen.
And that's why they have to give them the steroids.
Exactly. This is why one of the first things that they do is treatment with antiviral, which is the most popular right now, is remdesivir, and then they give also a steroid on top of it. Here's the thing. the majority of these patients that usually have some sort of comorbidity, the moment that you intubate them, it works against them. Do you remember in the beginning, back in like February or March, we had the ventilator shortage? Anybody know why? Because we were afraid of spreading this virus. So if you didn't tolerate, in the acute setting, if you didn't tolerate 6 liters nasal cannula, I was not going to put you on BiPAP because BiPAP has that leak. And now I'm inflating an infected lung, and when they exhale, where's it going to go? And we didn't know what was going to happen. So we tubed everybody.
Yeah, that's what I heard.
That's what led to the shortage of ventilators.
Please come to patient 2 and answer the call and say hello to the line.
So,
Please answer the phone call and patient 2.
So as we started getting more of a patient data, there was the European Respiratory Journal of Medicine came out with a study and said, oh shoot, all COVID patients are not the same. They're not. We have 2 types, what they call phenotypes. They have phenotype H and phenotype L. Now,
Respiratory to 27B, respiratory to 27B, please.
good? Good. So, phenotype H patients, when they were brought in to the ER, we did a CT scan on all patients. Phenotype patients, H had clear CT. Phenotype L had your classic interstitial pneumonia showing. Both needed oxygen. We intubated both. The problem is that one did not need such aggressive therapy. We noticed that yes, patients phenotype L that had that positive pneumonia CT, yeah, they needed some sort of respiratory intervention. Not these guys. These guys, when we looked at their labs, all of them had an elevated D-dimer. And does anybody know what D-dimer does? It measures clotting factors. So all of these patients had microclots. And what did we do? We fed them positive pressure. That clot got worse, and they couldn't oxygenate anymore, and they ended up dying. Does that make sense? So we noticed that with some sort of blood thinner, along with antivirals, along with steroids, they started getting better. But now we look at our phenotype Ls. Our phenotype Ls usually had also comorbidities, most commonly diabetes, and as you know, any patient who has diabetes has an issue with healing. And what are we doing to the alveoli with positive pressure? We cause microclots. They never got better. Their ARDS got so bad that not only that, what did we have to start doing to them? We had to start proning them, because we have a large organ in the front of our chest that's called the heart. Takes up a lot of space, right? So if I were to get if I look at a tree and I get and pick every single leaf and I put it on the ground, the surface area of those leaves is going to be greater than the trunk of that tree. Does that make sense?
Yeah.
So there's more surface area on our back of the lungs that gives us more room to improve oxygenation, which is why patients always respond better to proning, right? Unfortunately, the micro-injury was so bad that they never recovered. They suffered from hypoxia. Hypoxia led to multi-organ failure, which is why I asked you, if you had to choose a battle, which one are you going to choose? Oxygenation. And that starts with adequate eye times. At the base of everything, it starts with adequate eye times. Okay? Now, if in the end, unfortunately now, our patients have gotten so bad that they have actually needed something called external corporeal, ECMO.
Yeah,
ECMO. So it's basically a bypass for the lung, right? Unfortunately, and this is the reality of it. I'm trying to get all political, but unfortunately, not everybody qualifies for that. Anybody know?
I'm just curious, because ECMO is very expensive.
Does anybody know how much it costs? Well, it lasts 14 days. One round is 14 days, and you better have insurance because it is 1.5 million
Yeah, I know.
per round.
And not every hospital.
And not every hospital has it, assuming there's a technician on board.
Yeah.
Right.
Right.
So,
Okay.
yeah,
So
So ECMO is like we.
that is a
oxygen
Hail
into,
Mary. Right.
patient
These are your
blood.
lungs. The machine out here is taking your blood around your lungs and circulating it back. We are oxygenating it
the
externally.
blood, yeah,
Yeah.
yeah, that's what.
External
You guys do?
So that's
corporeal
like doing,
membrane. Yeah, that's what it stands for. External corporeal membrane oxygenation
Yeah.
That's like doing bypass.
on the lungs.
For
Yeah.
almost like what do you do in surgery when they
Yeah,
put
yeah.
the heart
Cardiac
surgery?
graft. Yeah,
Yeah.
Cabbage.
Mhm.
Right. So this is what we're looking at. So when it comes down to it, we're looking to see at these patients. Which is why it is important if your patient is not ventilated and positive COVID, take a look at their chest X-ray or their CT. It'll determine how you need to go about their therapy and how aggressive you need to be. Okay? If the patient is an L type, meaning that they have a pneumonia type, then swelling is already happening in their lungs. You intubate them, and what happens? You're gonna cause more swelling, more shearing, and now there's something called the sequential organ function index that all the doctors look at. And they say, well, if you're over the age of 65, your FiO2 keeps going up, your pH is going down, your meds are going up, all your vasopressors, they keep going up, you are 95% gonna die.
Yeah.
So, how do we help decrease this? As simple as controlling an eye time, we can go ahead and try to minimize this injury with these patients. Now, remember how I said that we have to chew?
No, I just had a quick question.
Now, do you remember how we said that when we choose a battle, when we're forced to go into pressure control and stuff like that, we have to look for oxygenation, right?
Mhm.
So, we are going to focus back in before 2000, our old school thought was 8 to 10 mLs per kilo. High tidal volumes, low respiratory rate. But the study showed that a lot of these patients were going into ARDS. Too much shearing. What was the culprit? Old school volume AC.
Yeah, now they like low tidal.
Yes. Why is that? Because less shearing.
Yeah.
So when your shearing is so bad that you're forced to go into lower tidal volumes, how do you minimize the shearing on the alveoli? Keep your PEEP high. Your PEEP high will not allow for that shearing effect constant all the time.
It keeps it open.
Exactly.
Yeah.
Which is why part of ARDS-NET protocol is high PEEP, low volumes, and a high rate. Rapid shallow breathing at a high PEEP level.
Yeah.
Now, but how do you do this to a patient that just came in that's awake, responsive, but in distress, positive COVID, not intubated? You don't have BiPAP as an option right now.
Well, but they are using BiPAP now.
That's right. High flow nasal cannula. High flow nasal cannula can provide PEEP to decrease the shearing effect non-invasive. Which is why I moved my stocks over to the high flow nasal cannula.
But a lot of the doctors aren't ordering this.
Why is that?
Aren't ordering the high flow. I don't know.
There
why,
are two
but-
schools of thought on this, and usually depends on where they're getting their information from.
Mhm.
Is there was a study that came out again from the European Journal of Medicine that said that high flow nasal cannula as an aerosolizing agent,
Right.
which means anytime you hear the word aerosolize in COVID-19,
You don't want to get an air, yeah.
right, which is true, it is. But what he didn't tell you is that they looked at high flow nasal cannula from 30 to 60 liters, and they put a black light with some smoke, and they put patient on a nasal cannula with a mask, and they saw that the aerosolization factor was only about 17 centimeters on the chest. So if you're all up in their face with no mask,
Then yeah.
for sure, yeah, and always, I always recommend an N95, please, okay, because we're still.
Right. Yeah.
Listen, it's airborne. It's airborne.
Alright.
Okay, it just depends on how fast, how long it lasts for. Okay, right. So it defies gravity for minutes, and some studies say hours, which is the definition of aerosolization. So we want to introduce some sort of PEEP to minimize the shearing effect on these patients. So again, I'm working backwards, but still, we want to make sure that when we look at these patients, we want to minimize the shearing. You do not at this time want to introduce any type of nebulizer therapy. All meter dose inhalers, because again, the word aerosol is a no-no, right? And you want to introduce any type of steroid to minimize that swelling.
But most of what you're talking about, correct me if I'm wrong, this is more of an acute care setting. Once they kind of get here,
Right.
we don't really,
Do you have high flows here?
we have
We do.
hospitals here.
Yeah.
But
Been using them on post.
yeah, they've
Yeah.
already went through the whole,
Right.
yeah.
But the thought is also to try to prevent any type of aggressive, unnecessary therapy on these patients. You want to start off with high flow. As a matter of fact, they'll say, "Oh, high flow nasal cannula." Some hospitals like Good Sam, we're topping off at 40 liters per minute because of that scare, right? And some people don't want to accept the studies, some people don't. So we're just okay. We'll meet you in the middle, 40, right? So we'll top off at 40, and if they don't tolerate that, then we'll add a non-rebreather on top of that as well.
We did that.
Right. And then we put them prone, and if that doesn't happen, now remember, patients that are positive COVID non-invasive, we are allowing them to be saturating in the low 80s.
Mm.
We are allowing them, because if I introduce that tube, what do you want? A saturation of 79 or a 95% certainty of death?
Right.
Let's battle the oxygen real quick, right? So we'll do everything possible pre-intubation until we're forced into that corner. If you're forced into that corner and the patient is not in distress, I would recommend you start off on PRVC, which will always aim for the lower inspiratory pressures, decreasing your PIP. Remember, you're going to look at your plateau pressures. What else? What else?
Pressure and
PF ratio.
PF ratio. What else?
Peak pressure.
Peak pressure, right? And if all these are not looking good, your argument is to go over towards
TC.
pressure control. We have your rate, and then you have your inspiratory pressure. And how do you calculate inspiratory pressure?
Plateau pressure
Minus
P.
Cool. Plateau pressure minus peak. Ideally, you want to start off with an inspiratory pressure less than 30, because that's the cutoff on injury. You can go up as you can in increments of 3,
Right.
and you want to aim for tidal volumes at around 6 mLs per kilo, okay, and stay there. Now, if your numbers start getting worse on pressure control, then we have a nationwide protocol called ARDS-NET protocol that says rapid shallow breathing with high peaks, correct? Rapid shallow means 4 to 6 mLs per kilo tidal volume. Respiratory rate greater than 20. I've even had patients on respiratory rate of 36. Okay? Just to get that movement going, okay? Peeps of 10 or greater.
Respiratory to section 1, Sharif to section 1.
Okay, and you want to make sure that if possible, to help improve oxygenation, you
Wrong.
No.
prone for 16 hours, supine for 8. Okay, now that's just, I'm not sure if you guys are there yet, that's more of FYI, okay?
Right,
If you want
right.
to take the initiative, like, hey dog,
Right.
let me
But as much
tell you what to
as,
do.
But for the
so what,
proper.
so what,
Yeah.
You can.
I think is important for us to take away here with the PR, because we're never gonna, we're never getting to
Right,
that section.
yeah.
So our management of these patients on the PRVC mode of ventilation, we need to start looking at our plateau pressures.
Exactly. Now, does everybody know how to obtain a plateau pressure on here? No? Come over here. Does everybody over here? So,
Respiratory test.
there's a little button here that says inspiratory hold. So I'm gonna go over here where it says main. I'm gonna go to monitor. I can adjust this however I want. There's peak. I'm gonna go over to plateau. Where are you? Give me the plateau pressure, bro. Is it on here? I don't see it. Peak means peak. I can do it a different way. Thank you very much. So I'm gonna look. Where's my settings button? Okay, so I'm gonna do an inspiratory hold. Come on. Inspiratory hold. Airway pressure, water pressure.
There you go.
Thank you. There it is. And please. Not capturing. Not capturing.
We need, is it because you're in
No.
your person involved in?
PRVC. Yeah, you're right.
Yeah.
I apologize about that.
We're all edit this part out.
Here it is. Still not capturing it. Is it very well button?
Wouldn't surprise.
It works. Night shift has it set all the time. Try going straight into your AC mode. It'll show you your inspiratory hold on there. Go into get out of the. Now, see that inspiratory pause?
Right there. So, what we're looking for when it works, I'm doing that inspiratory pause there. 1, 2, and then release. You want to freeze, and then it tells you right
What the
there.
pressure was. And what's this at?
27.
Right.
So that would be the inspiratory pressure you want to aim minus your
Peak. So 25.
exactly.
Okay.
22.
22.
Yeah.
Sorry, 22.
22. So that's the inspiratory pressure that you would start off at on pressure control. And if it's more than what your tidal volume goal is aimed, then you can decrease the inspiratory pressure, which then will decrease your PIPs.
Now, when we're in PRVC mode, it calculates
Automatically.
the plateau pressure, and then
Your compliance.
it automatically
Yeah.
calculates the compliance.
It does it for like 0.4, when you switch over, like 0.4 milliseconds, it'll take your plateau and your compliance, and it'll do the inspiratory pressure based off of that. So every breath it'll calculate.
And so it's adjusting my PIP per breath.
Inspiratory pressure, right. It'll change your PIP, correct.
Okay. And based off of the
Lung compliance.
compliance.
Exactly.
Okay.
Mhm.
All right.
Yeah.
And then
So this is again, set it and forget it.
Right.
All you have to do is make sure that you have an adequate eye time.
Right.
Because eye time can cause shearing or lack of volumes to be delivered.
And we should start at 1.
Yes. Aim for an IE ratio that's between 1 to 2, 1 to 3 normally.
Okay.
Okay, you want to avoid I times less than 0.8 because remember, you want that. You want this pause there, which is what holds your pressure and it improves your oxygenation.
Okay.
If you don't have that pause, it's not gonna. Your pressure's not gonna be held, or your volume's not gonna be held and met, and you're not gonna help with oxygenation.
Right, and that decreased eye time is causing me not to meet tidal volumes.
Exactly.
Okay.
Exactly.
All right. All right, got it.
Question, comments, concern, critiques. I am here for all.
Actually, a very good informative class, man.
So remember,
Very good.
pressure control, even though it is scary, you want to make sure that you are forced into that, and these are your arguments for it.
Okay.
Okay? And you all know how to adjust inspiratory pressure, how to set it. Be careful not to go up too high. This is where you might have to, guys might have to get together and see what the maximum amount of inspiratory pressure might be, because if my peak pressure, if my delta pressure is 20 and my peak is 5,
Yeah, it's effectively 25.
my PIP is 25, right? Which is cool, no problem. But what if my patient's not oxygenating right now? It's 15.
All right, now you're at 35.
But what if my tidal volumes are low?
All right. So now you're in damage area.
Exactly.
Okay.
This is why you have to know how to adequately adjust your tidal volume and know which demon you're going to fight.
Okay.
Does that make
Alright.
sense?
Okay.
Okay?
Got it.
Cool. Questions, comments, concerns? I know it's a lot of information. And I'm here. Please let me know. There's no such thing as a dumb question on camera. I'm kidding, no.
Right.
But I guess the biggest question is that I receive, especially from students, is how do I know, like my tidal volume is correct, or well, how do you know if your tidal volume is correct on volume AC? Well, you want to do ideal body weight,
Right.
and you look at your CO2. If your CO2 is normal, if my inspiratory pressure is 20 and my PEEP is 5 and my CO2 is 40, I ain't touching nothing. Leave it alone. And I still have that little pause there. Oxygenation is great. Guess what? I'm going to be working on decreasing my FiO2, right? So why is it that also, in lung protective status, you should anything that's greater than 60% FiO2. Sorry, that was really important. I missed that. 60% FiO2. Why is that? Because well, that's true. Yes, that's right. So we have what they call absorption atelectasis, or also known as nitrogen washout to all the old cats out there. And we also have oxygen toxicity. Okay. Now, with oxygen toxicity, what happens is that when you have 50% FiO2 or greater, you have in the brain, in the central nervous system, free radicals that overproduce surfactant and cause fluid overload. So what happens to your oxygenation? If my O2 is trying to get in, is it going to go through?
No.
No. So you have a little monitor on your finger. What's that going to do? SpO2 is going to go
Down.
low. Oh, what's your first response?
Increase.
So what's going to happen? Free radicals are going to increase again. More surfactant. Machine's going to go down again. And what's going to happen again? You're going to increase the FiO2 again. We call that the vicious cycle. Where oxygen is not the solution, it is a problem. So how do you get out of that? You need to go into higher levels of P, which is why you need to focus on lung protective strategies. If you focus on lung protective strategies, it'll help you get away from higher levels of oxygenation. Cool?
Got it.
Awesome.
Damn.
All right, well, thank you guys for your time.
Thank you
Thank
very
you.
much.
Thank you so much.
That was awesome.
Always great to come see you guys.
Awesome class.